As a generalist, you start by educating the patient and her partner. Those who have rotated with me know that I start the first visit with a drawing in which I clearly state how a couple gets pregnant, the life of the ovary, the life of the sperm, the function of the tubes. Following that, you'll take a detailed history. Most of your evaluation can be done with just the history. You will be able to make a preliminary diagnosis, but you still need to complete some tests and studies, and that should be done within 2 or 3 visits. And after that, the second or the third visit, you will be able to complete your assessment and plan. Remember, you are not promising a baby. What you are promising is to explain that couple why they haven't gotten pregnant. Part of educating the couple includes teaching them when to have intercourse if they want to get pregnant. The LH stick or the ovulation test is very convenient for that. Be aware that some patients may tell you that yes, they are timing intercourse and they are timing with an app, a computer app, and that doesn't work because it doesn't quite time the onset of the LH surge that will trigger ovulation. So how to use the LH stick or the ovulation test? Ovulation usually happens about 14 days before the next period. So have the patient telling you the dates of the first day of the last couple of periods to see how long their periods are. Of course, this doesn't work for women with PCOS because in PCOS, for one, the patient will have oligomenorrhea, for two, patient is not ovulating, and for three, they may have a high LH throughout the cycle. So don't use for, only use for patients who have regular periods. So the LH surge onset can be detected in urine 1 or 2 days before ovulation. For most women, this will mean that you start testing the urine around cycle day 13. They must test the first urine in the morning and don't test again for the rest of the day. Either it's positive or it's negative in the morning. But once it's positive, tell them to start having sexual intercourse for 3 consecutive days. You must also clarify that they should feel free to have intercourse whenever they want during the rest of the cycle. You may also want to explain how long the sperm lives and how long the egg lives, so that they realize how important is the timing of intercourse to catch an egg that is still viable. As a GYN surgeon, when you are operated, respect the ovaries. Even a small sliver of ovary has an incredible number of follicles that can be used. Mind the tubes when you are doing an open laparotomy. Don't use dry labs, always use moist labs. Consider chromotubation when you operate a nulli gravida, and consider ovarian drilling if indicated. A brief reminder of the infertility template. When you start looking at a case or presenting a case, all the following factors are relevant and will help with the diagnosis: age, gravity and parity, LMP, duration of infertility, whether it's primary or secondary, and the 6 factors. Do not rush through the factors when um, investigating the couple. Ovulatory factor, male factor, coital factor, cervical factor, uterine factor, and peritoneal factor. Take your time when you go over each one of them. So basically, I check very few hormones, TSH and prolactin, progesterone, this I may check several times, 17-hydroxyprogesterone I may or may not check, and something that is important to check is if the patient is rubella immune. You don't like her to get pregnant and next thing get rubella during the pregnancy. And that's it. Regarding a male with infertility, specifically a male with impotence, I may want to just order a prolactin and a testosterone in the partner, even though we usually send the partner to a urologist, but I may order a prolactin because if the impotence is due to hyperprolactinemia, just treating the man with bromocriptine or pergolene may solve the problem and they may get pregnant. Same if your patient, if the female has hyperprolactinemia and that's the only problem, it's very easy to get that couple pregnant. Ovulatory factor. Does the patient have irregular periods? Amenorrhea? Obviously she does not ovulate. Thus check prolactin and TSH. If the patient has regular periods, confirm ovulation with an LH stick. This is a test that is done in the urine and usually checking the first morning urine around cycles days 13, 14, 15, 16. Check progesterone in luteal phase. A plus-minus test in the patient with irregular periods is a 17-hydroxyprogesterone to rule out late-onset congenital adrenal hyperplasia. Regarding the male factor, does he have children? Does he have varicocele, history of trauma, hernia, asymmetric or undescended testicle, surgery? A semen analysis must be done in all cases. It's not covered by medical. If the patient has Kaiser, he may call the advised nurse on the phone and get it ordered and get it done. Otherwise, the cost is $100. You can find the forms to order this test in your S drive. We are not doing a semen analysis anymore at VMC. Before you send the patient on his merry way, give him instructions. He shouldn't use a lubricant when he masturbates for the semen analysis. Advise him to take a magazine or pictures or whatever motivates him. The semen should make it to the lab and to be under the scope within 30 minutes of masturbation, and the interval should be not more than what the couple normally has for intercourse. Once you get the results will come to you. Look at the volume, concentration, motility, and morphology. As OB-GYNs, we don't treat the male. We usually refer the male if there is a problem, but you can already advise on no smoking, not using tight shorts or underwear, and stay away from heat and radiation. Coital factor. The frequency is important, but don't ask how often you have sex. Give the couple options. Do you have sex once a day, once a week, once a month? Do you live in the same house, in the same town, in the same state? I often have couples where the partner is, let's say, in Ethiopia or in Europe. So that's important to know. Do children share the room or the bed? Does ejaculation occur inside the vagina? And ask more than once, since history may change. Cervical factor. It's important to document last PAP for obvious reasons. Check immunization status for HPV for both partners and complete it if needed. And get a history of lip or cone. And since I'm here, I would recommend you also get a rubella test. And if the patient is not immune to rubella, this is a good time to give her the shot. Uterine factor. You'd be surprised how many times a patient has forgotten that she got an IUD. Even myself, I had a patient referred from GYN-onc, and I assumed they had removed the Mirena, but it was still there. And it was very embarrassing when one of my colleagues found it out. Uterine factor may also include polyps, submucosal fibroids, and abnormal shape of the uterus. All those can be seen in an ultrasound or in the HSG or SIS. Tuboperitoneal factor. At this point, elicit a history of PID, salpingectomy, endometriosis, other pelvic surgery, or rupture API. The HSG has the additional, HSG is hysterosalpingogram. It has the additional benefit that some women get pregnant in the next 1 to 6 months after the HSG was done. Ordering the hysterosalpingogram. The patient must have a recent negative STD screening. I personally like to order doxycycline 100 milligrams BID for 5 days, starting the day before the procedure. However, I review the update recommendations, and they recommend 100 milligrams BID starting on the day of the procedure if the tubes are dilated, which I don't think is a good idea because you are not going to be there and the radiologist may not be aware of communicating with you. So I always order the doxycycline when I instruct the patients about the HSG. Condoms between period and the procedure. The patient needs to call to schedule the procedure during the period, and of course we don't want her to be pregnant before she gets radiation. The order can be found in your S drive if you are going to do it outside BMC. Mark that you want a hysterosalpingogram, and as I said before, the patient will need to call radiology during her period to schedule. Patients who are in Valley Health Plan, the procedure is covered for them, and if otherwise they have to pay, as I said, find a form in this drive. Patient calls during the period, and it will cost $500 at VRI versus $1,200 at BMC. Okay, let's assume we have a patient with patent tubes. normal semen analysis, and her most relevant problem seems to be oligovulation or anovulation. The most likely diagnosis in our population is PCOS. We often talk about Rotterdam or NIH criteria. Using the Rotterdam criteria, you'll see it in the next slides, the prevalence is 10% of anovulatory patients have PCOS, or NIH 6%. Most studies nowadays are using the Rotterdam criteria. The Rotterdam criteria adds the ultrasound. You'll see you don't need an ultrasound to make the diagnosis, and having a positive ultrasound doesn't mean that the patient has PCOS. So for the Rotterdam criteria, you need 2 out of the 3. Hyperandrogenism, oligovulation, those 2 are per history and physical exam, and then an ultrasound with more than 12 follicles, or more or equal than 12 follicles in each ovary. Those follicles are between 2 and 9 millimeters, or a total ovarian volume of 10 mLs. For the NIH criteria, all of these are required. Again, hyperandrogenism, oligoovulation, but you need to exclude adrenal hyperplasia of late onset, Cushing, and hyperprolactinemia. So the last of the criteria are really lab tests. I met this mom and her daughter. I met them in a bus in my hometown in March, early March, when we didn't know about coronavirus, and they looked so happy. And I thought, this mom never had PCOS. She was there, slim, with 2 of her kids, and this girl was adorable. Why do I include this slide? Part of your educating the patients should be to bring up age, and that they may want to start considering getting pregnant if they are approaching their beyond 30s. We are so used to reading in the news about older people getting pregnant. Sometimes we see them in the board, but the truth is that there is a decrease in fecundability that is abrupt starting at 35, but it starts to be seen at age 30. So you may want to let your patients know when they come for even a pap smear. As you know, PCOS, in addition to damaging the reproductive system, may affect the metabolic system and dermatological system. You can find hirsutism, acne, and acanthosis nigricans. The patient may have insulin resistance, hyperinsulinemia, excess fat tissue around the liver, obesity, increased prevalence of diabetes and glucose intolerance. But obese women get pregnant too. So never tell a patient with PCOS that she will never get pregnant unless she undergoes ovulation induction. Many of them may get pregnant spontaneously. What happens in PCOS? What is the hormonal role? Well, we call PCOS a vicious circle because it can start anywhere within the endocrine orchestra. The ultimate factor is an androgenic milieu around the ovary. For ovulation to happen, the ovaries may have an estrogenic milieu. And how we get to there is an increase in LH pulse amplitude and frequency, which increases ovarian secretion of androstenedione and testosterone. This may be due either to the excessive LH or insulin. The bottom line is that there will be oligoovulation. Always keep in mind that you should always look at the endometrium for hyperplasia and have a low threshold for biopsy. So the million-dollar question, do we use Clomid or Femara, letrozole or clomiphene? I get asked this question by my colleagues all the time. The number one step for ovulation induction is weight reduction, weight loss, weight shed. Do not fat shame the patient, but do explain to her that with just losing between 5 and 10% of her current weight, she may start ovulating on her own. Smoking cessation, reduction of alcohol consumption are also important, but weight reduction is so very important because even with Clomid or Femara, the patient may still not get pregnant until she loses some weight. And of interest, the National Health Service in the UK does not approve for a free IVF for women with BMIs above 30. When to use Femara when Clomid? If the patient got pregnant on letrozole in the past, by all means, just use the same. Same letrozole, same dose. A meta-analysis in 2009 looked at 4 trials, 662 women with similar pregnancy rates. Well, letrozole may have a higher live birth rate and ovulation rate. So overall, people are now inclined to use letrozole. But letrozole is off-label, is more expensive, and you can only increase the dose 3 times, like go from 2.5 to 5 milligrams to 7.5 milligrams. The clomiphene mechanism of action, and in fact the letrozole, is very similar. They both end up in a pathway that will increase FSH, except that clomiphene is a non-sterile compound, very similar to estrogen, though. It blocks the estrogenic hypothalamic receptors, which in turn results in releasing more FSH from the anterior pituitary. But the problem with the Clomid is that it has anti-estrogenic action all over the place, and this may explain the discrepancy between ovulation rates and pregnancy rates. So the patient may ovulate, but the endometrium may be not well prepared to receive the embryo, and there may be a higher level, a higher number of abortions. Letrozole is a selective aromatase inhibitor. So remember, Clomid was a low estrogen, while letrozole inhibits the aromatase. Thus, it prevents the conversion of androgens to estrogens, and it results in a bottom line increase of FSH from the anterior pituitary. Also, at the ovarian level, because the aromatase is not functioning, there is more of a sensitive to FSH when it receives the increased FSH. And the letrozole doesn't have the anti-estrogenic peripheral action that Clomid has. The other advantage is that it's rapidly clear due to a shorter half-life, only 48 hours, as compared to Clomid, which may take up to 2 months due to its prolonged half-life of 2 weeks. While this is a con, but it may also be a pro. Many patients, when giving clomiphene, don't get pregnant on the month you prescribed, but get pregnant without treatment in the following months. Clomiphene has the advantage of having been used for 40 years. It's 40 years. Again, works by increasing FSH. When you start giving Clomid, the recommendation is to start with 50 milligrams a day for 5 days, days 3 to 7. I personally start with 100 milligrams a day, unless BMI is normal. So I think this also may be a reason why the papers favor letrozole over Clomid. I think what happens is they start with 2.5 of letrozole and 50 of Clomid, but in reality they are comparing apples and oranges. They should start with 100 of Clomid, but that's my personal idea. So start on cycle day 3, check progesterone on cycle day 23. Ovulation occurs later with Clomid, so when a normal ovulating person usually ovulates on days 14, 15, with Clomid, the first day of Clomid acts as if it were the first day of the cycle. So ovulation happens later. And menstruation will also be delayed. So many times patients think they are pregnant, and no, it's that ovulation happens later and menstruation comes later. If with 50 milligrams, 100 milligrams, patient doesn't ovulate, you can go to 150 milligrams a day, 200 milligrams a day, and I go to 250 milligrams. I add metformin BID when I'm at 150 milligrams and above, and document the risk for multiple gestations. In my experience, I never had a multiple gestation, and the cases that I know are due to clinicians giving Clomid to patients who already ovulate. Side effects of Clomid: hot flashes, abdominal discomfort, nausea, breast tenderness, hair loss, insomnia, blurred eyesight, and of course multiples. While with letrozole, you may have hot flashes, abdominal discomfort, nausea, insomnia, much less multiple gestations, and you may have other side effects, but are mostly seen with long-term use of letrozole in patients with postmenopausal patients with breast cancer. So remember that letrozole is a medication that is usually used as an adjuvant therapy for the postmenopausal patient with breast cancer, and the ovulation induction is an off-label use. The success rate with Clomid is quoted as a 6 months live birth rate between 20 and 40%. Once ovulation is documented, let's say your patient ovulated with 100 milligrams a day, keep the same dose for 6 months. By then, she should have gotten pregnant. Each month, document ovulation with LH stick and with progesterone, because you may notice that a patient who ovulated on 100 milligrams then needs an increased dose, and insist on timing intercourse. Okay, I'm repeating myself. The letrozole is an off-label use. It's more expensive. The starting dose is 2.5 milligrams a day for 5 days. Same start date, 3, 4, or 5 after menses. So not after they are finished, but day 3, 4, or 5 of the cycle. Increased by 2.5 milligrams if each month if ovulation did not happen, up to a max dose of 7.5. And ovarian drilling. You probably have seldom seen this done in our institution, but Dr. Brown has been doing a few for some of my clomid resistant patients. It works by destroying the tissue that makes androgens. You basically poke holes in the ovary with laser or thermic, and it sort of results in the same that you might have read in the old days. People did wedge resection for the Stein-Leventhal ovaries. Here's a paper with some data. And now, when should a generalist refer for ARDS? You must complete the workup before doing the referral. So the patient should have had her HSG or SIS, semen analysis, and progesterone. If all these are normal and she has unexplained infertility, is a valid reason for referral. Definitely she has tubal factor, male factor, unless there is total azoospermia, in which case if they are going to use donor semen, you can coach them on how to buy donor semen and do the self-insemination. If you are unable to induce ovulation up to the max dose of Clomid or Femara and ovarian drilling, if the patient has patent tubes and other factors normal, wait for 6 months after the HSG, because the HSG itself may improve her chances of conception. When referring to ARDS, to IVF, you must provide the patient on more than one clinic within your zip code. Those clinics have to report their outcomes. It's mandatory to be certified each calendar year. So the patient may want to check what the success rate of the clinic is and what type of patients they admit to have that success rate. Of course, the success rate will change in the context of age of the patients they take, the number of embryos transferred, if they do ICSI, the history. Patients may consult you about doing IUI if they have patent tubes with ovarian hyperstimulation. I tell them it's not worse, it's not better than the success rate for sexual intercourse. Of course, it is cheaper than IVF, but what's the point if it doesn't work? Many IVF programs will offer them 3 IUI cycles. Again, they seldom work, and then they still need to pay for IVF. Check the CDC map, because the laws change state by state about what's mandatory to cover. Even IVF is free in many states in the East Coast. And then you may want to let the patient know that there are infertility loans, and this is a useful website. So a couple may get a loan to pay for their IVF.